a question about I thought I may have overread, but I thought they said that kidney disease was the seventh largest killer in the
Yeah.
US. Then I read that on here it says seventh, but when I went under the kidney thing, it said ninth. So is that just something old? And then it's because that was since
It,
ninth.
it I believe it's the seventh. But look at the date reference for what you've been looking at.
Yes,
Uh,
2019.
2019.
Mm-hmm.
The other reference you looked at.
Yeah, the one that said the ninth. So I'm thinking maybe it's climbed up higher than the others.
I feel like I've been quoting seventh for a while. So I'll have to look at what where the latest data has moved. But
Okay.
I mean, ultimately, it doesn't really matter. It's a top 10 killer.
Yeah.
It's one of the leading causes of death in the United States, and it's got connections or synergies to other top 10 causes of death, like type 2 diabetes.
Yeah.
Um, and then heart disease, but heart disease stems a lot of times from those diabetes, and also from uh, uh, hypertension, and then even anemia that our patients have, right? So
Yeah.
there's a lot of connectivity to other top causes of death as well.
Yeah.
All right, so let's get to renal anatomy and physiology. Okay, I think it'll be a good end of the week, and then segue into the next week to really dive into the patient.
Okay.
Let me share my screen just a second.
My glasses. Renal anatomy and physiology.
All right, so basically we're just gonna talk about the design of the kidneys and the urinary system, as well as the functions of the kidneys, which are very bountiful. So the kidneys do a lot. We've talked about that already, but we'll dive in a little bit, and um, really try to take note of this, and make sure that you lock it in. I think I told you guys, right? Like, you need to know those functions of the kidneys, and very well, because as a dialysis technician or dialysis nurse, like, we're there doing a procedure that is to replace renal function, and we need to do that adequately. If it's not adequate, then the patient's going to have more complications of kidney failure that can affect quality of life and quantity of life. So really important that you get a grasp on what the kidneys do. The renal anatomy, I'll be honest with you, like, you got to learn it, but like, we're not in there doing surgery, dissecting kidneys and doing the transplant surgeries ourselves. So you just got to kind of get a high level understanding of renal anatomy, like the parts of the kidney, and the urinary system, but the functions you really need to have on an intimate, like, have intimate knowledge of. Okay.
Okay.
So if you just dissect and open up the abdomen, cut through a membrane called the peritoneum, right? That's the one that is that abdominal lining. You'll see in there that uh, from the urinary system, that's not all the urinary system, right? But the parts that are the urinary system are the kidneys. So these little bean-shaped organs, right? They're about the size of a fist.
Is that you doing that little red dot there?
Yeah,
Okay.
yeah.
Okay.
So
Good.
that's the kidney, right?
Okay.
And they're little bean-shaped organs. They're about the size of a fist, and that's a very generic explanation for their size, but it's kind of the reference. everybody's got different size hand, right? You got little people with massive hands and big people with tiny hands, right? So I don't think it's the most accurate representation, but it's just like a rule of thumb or a guide for saying the size of the kidneys. So these are the workers. These are the ones that are gonna be responsible for processing blood every second of the day, every heartbeat. There's about a quarter of the cardiac output, the blood that's coming out of the heart, that's coming down and being supplied directly to the kidneys. Okay, so about 25% of the blood goes right to the kidneys every heartbeat. It's a bloodthirsty organ. Like for its mass, it's got the highest blood requirement of any organ in the body. Okay, for its mass, not the highest volume, but for its mass, the highest blood volume requirement. So per day, there's somewhere around 450, 500 gallons of blood that goes through your kidneys and filter. You don't have 450, 500 gallons of blood, right? So it's because it's like I said, every heartbeat, your blood is cycling through those kidneys all day long, every heartbeat, a quarter of your cardiac output. And it comes through like a vessel, a large vessel called a renal artery, goes into the kidney. And then there's some magic that happens inside that kidney, right? Like your kidneys eventually end up making urine. But like, how's that all happen? We'll take a look at that. So how is urine made? And then besides making urine, the kidneys do some other things. So some magic happens in the kidneys, and then whatever blood is good to go, right? Because that's what the kidneys are doing, is processing blood. Once it's done its job, then the blood will move out of the kidney through a renal vein and then circulate through the body. But whatever needs to be excreted or taken out, right, will go down that pale tubing, that one that's right down there, right? It's called a ureter. And two kidneys, so each kidney has a ureter, right? And then those ureters are basically carrying what the kidneys have filtered out and identified as excess, so like excess fluid and electrolytes and waste. It sends down through that ureter and hits your bladder. And then eventually your bladder gets full and you got to pee, right? So you will evacuate that urine through the excretory process. You'll go pee, right? And hopefully we have about the same amount of pee as the fluid that we're taking in every day. So we're not holding on to excess fluid, right? So that's the basics of the anatomy, like the high level, right? It's two kidneys about the size of a fist. Their location is like really like close to your back, right? They're called retroperitoneal. Retroperitoneal. Okay, so like on the back side of the peritoneum. That if you were to like dissect from the back, it'd be like you have some skin, a couple ribs, or a skin, some ribs, some muscle, and then the kidneys, and they're relatively susceptible to injury.
Are they under the ribs?
Yeah, like, just under the rib. Yeah, like the last rib. So if you were to kind of hold your ribs on your back and then work down until you don't feel any, like you feel the last rib, it's kind of like right there. So I mean, I could go and jab you in the kidney, right? Poke you in the kidney, and it's why like people who fight or like kickboxer, boxer, sometimes they have kidney injuries related to their traumas. Sometimes they have acute kidney failure or acute kidney injury related to those traumas, car accidents, stuff like this, right? People can get stabbed in their kidney or shot really, really easy. It's a fairly superficial organ. Okay. So retroperitoneal, two kidneys, about the size of a fist, that process blood all day long, and whatever you don't need in your blood anymore, they send it out down the ureters, two ureters, right? each connected to the kidney, works down to the bladder, where eventually you will have that spasm, that urge to evacuate and urinate. Okay. And like I said, your kidneys are processing blood all day long, and in reality, they only cause the excretion of about 1 to 2 liters per day. So you pee about 1 to 2 liters per day on average.
Okay.
I shouldn't say you. I should say the average person pees
What
1 to
you meant.
2. Yeah. my son's girlfriend been staying here lately. She's pregnant, and I think she pees probably 5 liters because every night it's like
Yeah.
every 10 minutes, like I hear the door, like, oh God.
Okay.
So that's your high level urinary system, right? But let's take it down to the kidneys and look inside and see what really happens in there. So I don't want you to try and memorize every one of these call out items, okay? Or even what you have called out in your book. Like don't worry about it, honestly, unless you're just an overachiever. That's fine. But like I said, this is not your bread and butter right here. Like the patients that we work with, their kidneys have failed, right? They are usually not normal kidneys anymore. They're like shrunk up, atrophied. Sometimes they're even bigger because they got cysts all over them or something like that. But so this is the normal kidney, right? And that's not typically what we're dealing with. We're not dealing with the kidney itself. We're dealing with replacing the function of the kidney through that machine and the dialyzer, right?
Mhm.
But high level again, like let's look at this from the balcony, okay? Let's not dive too deep into the weeds. Like I want you to just kind of look like at the left picture and see that there's this like an outer binding to the kidney, okay, like a leathery binding, and I'll call it like a sausage casing.
Okay.
Kind of like that gives it some structure and some, holds it together. It's called a corpuscle, renal corpuscle. And then after that casing, then you got kind of this spongy meat, okay? And this spongy meat, like literally like a sponge, is full of things called nephrons, which are the tiny filters, the functional units of the kidney. The kidney itself doesn't make urine. The nephrons do.
Mhm.
And in that spongy part, like, can you imagine, like, hold your fist in front of your face and imagine 1 million to 1.2 million functional units in that fist. Like, look at your fist and think about 1 to 1.2 million things in there. How small are they?
Yeah.
Microscopic, right? They're tiny. So there's these functional units in the kidneys that are tiny, and about 1 million to 1.2 million in each kidney. So you got like 2 to 2.4 million nephrons that make urine, each of them. And collectively, they balance your blood. I every time I think of this, I get like, I'm in awe of the human body. Like, I try to get, like, even your group, there's 4 of you in your group. Like, if I gave you a group project, let's see how that goes. Right? No, do it this way. Or
Yeah.
somebody's not going to do their work, somebody's going to do their work. But the body, 1 to 1.2 million workers do their job. And the job is not like an individual job, it's a team effort. It's amazing.
That's from a different country, different culture.
What's that?
You said if you gave us teamwork, it would be hard. But I'm saying if you gave it teamwork from a different culture or country, yeah, we'd all work together.
Yeah,
Not here.
yeah. But you understand my point, right? Coordination is tough, and I mean, like, look at bees, right? Like, it's kind of like how bees do this one thing. Like, it's the kidneys are amazing because it's each of these tiny individual cells, these nephrons that are doing their job collectively to keep like this volume of blood in your body all consistent all the time, to keep it in something called homeostasis, this internal balance of chemistries and fluid um, your kidneys keep that 24/7. Right. So about one in that spongy part, which is called the cortex. Okay, the cortical substances, the cortex. All the nephrons are out here. Okay, and it's going to be kind of red if you were to actually see a kidney, much redder color, full of blood. Okay, and then what they're doing in those nephrons, and we'll get to that, is they're filtering everything out of the blood except for like your red blood cell and your white blood cell and your protein, like stuff that shouldn't end up in urine doesn't get filtered out, but everything else does, like your water, your waste, your electrolytes, everything gets taken out. And then your nephrons start to take back what you need. So they take it all out first, then they take back what they need. And then they also secrete some hormones like that activated vitamin D and erythropoietin and renin that we talked about. And whatever you don't need, your nephrons then take it from this cortical substance, so the outside, and whatever you don't need then comes into this part, the white, the clearer part, or the lighter color. Okay, and these are, just to cut right to it, these are going to connect to the ureter, but they have their names, and really, who cares? Like, minor calyx, major calyx, renal pelvis, ureter. Like, again, who cares? Like, that's not the big. That I'm not trying to like downplay it, guys. I'm just saying, like, at this point, this is not important to you. You know what I mean? What's important to you is high level understanding of the kidneys, high level understanding of the functional units of the kidneys, which are the nephrons. And then we'll break down what the nephrons do in each part of them, so that you do have a general understanding of the renal anatomy. But more so, like I said, you got to know that physiology. What are they doing? What are the kidneys doing? What's the accomplishment? Okay. If you look at the other side of the kidney, like, there's the ureter seal, and you're just looking not at the cut side of it, but the major artery that brings the blood into the kidney, called the renal artery, right? And think about it. This artery right here has to branch down to about 1 to 1.2 million nephrons. So think about your house. Like, the water comes in your house, right? And a big pipe. And then it branches down to your toilet and your sink and your shower and your water hose, to smaller pipes, right? And then when you, like in your sink, it goes in a drain, a small pipe, and then goes through a series of pipes to a bigger pipe to exit your house to the sewer. So that's kind of how the kidneys do it. It's like a big vessel, a big artery brings blood into the kidneys, but then branches down to microscopic blood vessels and the nephrons. And then whatever is the waste side of it comes from small to larger, right? So large to small in, small to large out. Okay. And then the other side of it, so renal artery in, and then renal vein out. Big vein out. But again, it has to come from the microscopic nephrons in this cortex, right? So from small vessels to larger, to then it gets to the vein and back into your general, like your general circulation. So here's the part that really, like, it's the functional unit. Like, if you were to pull out and magnify a cortical section there, which is the nephron, right? You see that wiggly yellow line with the little ball, right? That's the nephron. Okay, and you see, it's like, if you were to look at it here, it's actually like the whole span of that cortex, but it's microscopic. They're like packed in there super tight. Okay. And what will happen is blood will enter into this part right here, which is, you pull it out, it's right here. And I don't know what happened to my call out there, but that's called the Bowman's capsule. This white line right here, the outer side of it, Bowman's capsule, like the bubble. And then inside of there, you see the little red vessel goes in, and then it kind of balls up, right? Like into like a ball of yarn, right? It's a ball of capillaries. So it's like the blood goes into this glomerulus, or into the nephron as a whole, with a very microscopic blood vessel into that glomerulus, and it's under high pressure. Okay, and under high pressure in that glomerulus, it forces everything out of the blood, except for what should not end up in your urine, like red blood cell, white blood cell, albumin or protein, and platelets. Those things should not end up in your urine, so your kidneys don't filter that out. The glomerulus does not filter that out. The filter called the glomerulus, the pore size of it is smaller than red blood cells, white blood cells, plasma protein, or platelets, so they can't pass through. Okay, but it's large enough for water and waste and electrolytes to pass through. So in that little ball, 100% of everything except for those whole blood components that I mentioned is filtered out, all of it.
I had a question, Mr. Morales. So the glomerulus is the ball, and
the ball of capillaries,
and the Bowman
the filter.
capsule is what?
It's around it. It's just like a casing around it. So like you see that bubble. So everything will be filtered out of these red vessels, but then it's inside that bubble, and it'll work through this yellow tubing called tubules.
So the big ball is called the glomerulus. Okay.
The bubble is called the Bowman's capsule. Inside of the Bowman's capsule is the ball of capillaries.
Okay.
So it's like a ball of yarn.
And then what's the glomeruli? I'm getting confused with that.
The glomerulus is the ball of capillaries.
Oh, it's just another.
Glomerulus is the filter.
Okay.
Glomeruli is just like a plural sense of it, right?
Yeah. Glomeruli.
Okay. So blood goes in, filters out everything inside that Bowman's capsule, and whatever's not filtered out will just stay in the vascular space. You see, it goes like in this red tube or this red vessels here around, like kind of like spider webs around there. But what gets filtered out goes through this yellow tube. That's called the renal tubules, and that's going to eventually end up to be urine. It's just working its way through the whole channel, right? And what happens is everything in this ball, everything's filtered out, but as it works its way through that convoluted tubule, the vessels around those tubules start to take things back. So start to take water back, start to take sodium back and other electrolytes. And this is crazy. Like, think about it. Like the way that your body does it, like you guys have a fish tank before?
Yes.
Yeah. So like the way that your body does it is it takes everything out of the fish tank and then puts back what you need. Right. So with your blood, your body right in that Bowman's capsule and the glomerulus like filters everything out, and then as it works through the tubules, starts to take back what you need. Okay. If it didn't take back what you need, you'd be dead. Right. Like you wouldn't have the necessary fluid and electrolytes that you need in your body. So it filters, but then it takes back. So it's like it's really like a whole spring cleaning, right? Like when you go through your house and you just rip everything apart and then put it all together again, that's what your blood is going through every single beat of your heart, right? All day long, being stripped of everything and being repopulated with what it needs. So it's called, first part in that Bowman's capsule, guys, filtration. Okay. Second part is as it goes through the tubules, things start to get reabsorbed back into the blood, what you need. And then also in that network right here, guys, in this nephron of this, the network of blood vessels around the tubules, they're called peritubular capillaries, like all these red and blue vessels. They are also going to have a process called secretion. That's where the hormones come into play. They get put into your blood to help with your blood pressure or your red blood cells or your calcium absorption in your gut. So first, filtration. Then there's reabsorption, and there's also secretion of hormones. And then looking at that nephron, what makes its way all the way to the end. So look at the one in the kidney, and you see if it makes its way through all those yellow tubes, it ends up right there in the clearer part, right? The one that I told you right here is eventually going to end up the ureter, but it goes into a minor calyx, a major calyx, hits the pelvis, and then now it's in the ureter, eventually in your bladder, and then you'll excrete it through your urinary process. So that's the cut view of it, right? Same thing. This is the kidney cut. This one, we don't see the nephron, we just see the cortical substance. But if you were to magnify a nephron, there's the nephron, pull it out, and Bowman's capsule that has the glomerulus in it, tubules that carry all the filtrate, and peritubular capillaries that handle the reabsorption. So the 4 steps in the urinary process, okay? Filtration, reabsorption, secretion, and then last, excretion. So you pee it out. And about 1 to 2 liters of urine is the normal output.
Okay. 1 to 2 liters. Okay.
All right. So again, like, just what's the high level needs for your knowledge of anatomy? Know the urinary system: 2 kidneys, 2 ureters, 1 urinary bladder, 1 urethra. And Joanne, you gave a great detailed explanation of the anatomy in your discussion. That's good job. So 2 kidneys, which are really, that's your functional component of this, right? The rest of it's like plumbing. The ureters carry it down to the bladder to just get to evacuate it, right, for the excretion.
Mm-hmm.
And then what about this one? What high level? What do you need to know here? I think it's good to know just that there's like two layers, okay? The cortex, where all the nephrons are at, and all the filtration, reabsorption, secretion is going to be happening, and then the medulla, the inner part of it, where you have like the excretory component of the kidney, it's going to carry the urine for evacuation, right? So that you can pass through urine. So it's like this white parts in this cut, like a minor calyx, which is right where the nephrons dump into, then a major calyx, like the bigger component of it, then a pelvis where it kind of bends, and a ureter where it takes it down to the kidneys. Do I think you need to know all those? No. I like what I would say that you should commit to memory is the number of kidneys, the number of nephrons, the number of ureters, the number of urinary bladder, which is 1, and the number of urethra, which is 1 as well. And these are all normal numbers, right? The I guess the normal anatomy numbers. Are there people who have more kidneys or less kidneys?
Maybe less kidneys, but not more, right?
Yeah, there have been people with 3 kidneys. Yeah. So there are anomalies. There are anomalies. Okay.
Oh.
Yeah. So like, I mean, are there people with 11 toes? Yeah.
Oh yeah.
Yeah. So there's there's anomalies like that out there, but the normal anatomy is 2 kidneys. It's not too uncommon that people have 1 kidney though. And it's not too uncommon also that you do have 1 smaller kidney, but it's not like drastically smaller, but there are some people who have like very small, like 1 very small kidney that doesn't function normally, and may even have issues on the onset, like from birth. There are people who have conjoined kidneys, like their 2 kidneys are together. There are people that have larger kidneys. So again, we're talking the normal anatomy. Are there a million different scenarios that we could paint out there of, somebody who has this or somebody who has that? Yeah, absolutely. Okay. Even the configuration of this urinary system, there are people that don't have things attached in the right places, right? Like ureters connected to kidneys, or there's just like all sorts of anomalies that you can face in medicine or anatomy. I would say today, but it's probably always been that way, right?
I'm surprised about the 3. I'm still on the 3 kidneys.
From this one. Yeah, it's very rare. I mean, not as common, definitely not as common as the 1. I have known so many people who found out they had 1 kidney, going in for an ultrasound for some reason, and it's like, oh, and they're in their 20s or 30s and never knew. because like body is functioning fine. And actually, I mean, you can function with one kidney. It's just not the ideal circumstance, right? Because you can do living donation and live with one kidney a healthy life. It's what I say by not ideal is like just don't get careless for sure, because you don't got any backup, right? I have a friend. I got a friend. I don't know if you guys when you were here in California, Kenlyn or Joanne, if you know a guy named Philip Palmer, he's a morning anchor for I think Channel 7. He's a real tall, like handsome dude, white guy, like very professional looking, proper. But he gave his kidney away. I want to say over 10 years ago to another, like an actor, one of his friends, and yeah, he just lives a lifestyle of like really a disciplined lifestyle, you know. Watches his diet, gets regular checkups, doesn't drink, you know, because
George
it
did the same thing with his wife.
Say it again.
George Lopez, didn't he give his kidney? Oh no, the wife gave his kidney to George Lopez, I think.
Yeah, the wife gave the kidney to George Lopez. They ended up divorced shortly after, because he was like openly unfaithful, and Ann Lopez is still a champion for Donate Life. She like they do interviews together, like they still love each other. She's a beautiful person. I mean, that takes a lot, you know,
especially
to
a divorce right after.
Well, yeah, I mean, it takes a lot to take a part of your body out and give it to somebody because you love them, but it also takes a lot to not like spite them when they cheat on you, and then you feel like you wasted your kidney, right? That's not how she feels. Like she embraces the donation that she gave and the chance that she gave him. And they're good friends. Like she's really cool. She does stuff with Donate Life. It's an organization that you know promotes and provides education to people who are thinking about living donation, which is a very something that should be thought about for sure. Because like I said, you do need that kidney. It is a sacrifice. You know, as much as people say like, oh, you only need one kidney. No, like what we're seeing is people who donate their kidneys, they end up on dialysis later.
Oh, wow.
Yeah, so they actually get like a prioritization on the transplant list. If you gave your kidney away and then you end up on transplant list, you move up like, you know, quite a few notches on the waiting time.
I had a question about that. I was thinking about doing that for a family member, but if you, for example, if you end up on a transplant list and you have somebody that's willing to donate, do you still have to go under that whole rules thing, or do you get because you have somebody?
No, there's a living donor doesn't have the same like a wait list. It just has evaluation. So like everybody got to be in good shape still. Like you got to be in good shape if you're going to give your kidney away. You can't have health problems, right? Because then like, oh, we're doing harm.
Yeah.
Right? And that's the thing about living donation is over the years it's been like if it was 10 years ago, people were like, hey, just take your kidney out and give it to anybody. You know, like you just look on Facebook and find somebody to give a kidney to, right? Because you only need one. Now it's not so much like that because, like I said, we see people who are needing their kidneys, you know, like down the road, they're ending up on dialysis. And we know now that a living donation is doing harm. So it has to be like thoroughly evaluated to see like, is the candidate or sorry, the donor going to be able to withstand that sacrifice? We don't want to like take a kidney from somebody, get somebody off dialysis just to put somebody else on.
Yeah.
Right. And like the general rule for the surgeons and the evaluation, the transplant evaluators is, and this is a general rule, it's not an absolute, is donate down, not up. Like donate to younger, not to older.
Oh, I see.
Which that doesn't always happen, because like I know so many people who gave their kidney to their parents and stuff like this, right?
Yeah.
But yeah, what we see is later down the road, you know, not, I'm not saying it's absolute, but we see a lot of it where people ended up needing their kidneys, or they end up on with CKD, ESRD, and then graduating to dialysis themselves. So as far as like needing a kidney, if you have a living donor, then there's just the evaluations of the donor and the recipient, and everybody has to be able to do this, right? So do no
Mhm.
harm. But on the side of a cadaveric donation, then yeah, you'd have to sit on a list, and you're probably waiting, you know, 5 to 10 years, which just so happens to be the life expectancy too. So good luck,
Mhm.
right? Like
Yeah.
most likely you're not getting a kidney transplant. We can kind of look at it two ways from the statistics. Is your life expectancy will probably come before your transplant.
Oh,
And then the transplant itself is, you know, somebody has to die for you to get it. Now, I will tell you this, that something that's really amazing, and it just baffles me, because in the beginning of COVID, we couldn't get surgeries and stuff like this. There was all kinds of issues with surgical centers, right? And
yeah.
and we saw more transplants during COVID than ever. It's
Oh,
amazing.
wow.
I believe that 2021 was like double the normal transplant rate.
Oh, because of the
Um,
people's death, right? Because of all the people that died? Or
I I don't know that we have the exact I don't know that that's been published yet on why that happened, because one thing I can say is that we've always had a lot more kidneys than we transplant. There are so many kidneys that are thrown away, right? There are
oh,
so many. There's a real mismanagement of organs, and when I say mismanagement, I don't want to say it's like a negligence thing. I just want to say that it's a systematic thing.
mhm.
There's a lot of room for improvement. There's so many variables that happen with transplant, like location, blood type, which is the biggest, right? Tissue
Yes.
type, antibodies, like so many things that go into it. Biggest one's going to be the blood type.
Yeah. Oh, yeah.
Okay,
Yeah.
so again, urinary process, filtration, reabsorption, secretion, and then excretion from the nephrons into the ureters into the urinary bladder for your excretion in the urethra. All right, so let's look at the functions of the kidneys. What do they do? And we got like two major categories to functions. We have excretory and endocrine. Excretory is what we just talked about, when filtration, reabsorption, secretion, and excretion. Basically, you pee out the excess fluid, the excess electrolyte, the hydrogen ions or the acids in your blood, and then you also pee out your waste products like urea or creatinine or other waste products, even like drugs and things like this, right? So your kidneys are responsible for getting the stuff that shouldn't be in your blood out. And let's really try to understand this, that the blood is a small representation of all the fluid in your body. Okay, it's the blood itself is a very small representation of the 60 to 70% of the your body weight that is fluid, right?
Mhm.
So we can only clean blood, but like what if I ask you, like, what is blood? Describe blood. What is blood? Or what is it? What does blood do? Like, give me some high level explanations of blood.
You have iron in your blood. Um,
Okay.
it carries iron. God, does so many things. Oxygen. Um,
So let's talk about that one. Let's say oxygen, because that's kind of like a typical way that people think about blood is oxygen, and blood is what, like life, right? Like it's carrying life through your body, right? Carrying nutrient through your body, and that's kind of how everybody thinks about blood, is that it's got all this good stuff for you, right?
yeah.
But actually, and that's true, but actually, blood is also a garbage can.
Yeah.
It, it
That.
It truly is a garbage can. All the crap in your body that is in your bodily fluids, I should say, gets dumped into your blood. Okay, so like if you live in a house or an apartment, like you got trash can in your bathroom, trash can in your kitchen, trash cans in the backyard, all this kind of stuff. Then on Monday or Tuesday or whatever day, you take all that stuff out to the curb or to the bin, and then or hopefully from your house you take it out to the outside before not just once a week, right? Otherwise your house is stinking. But so you take all the trash to the garbage can, and then once a week somebody comes and picks it up, right? And then your trash cans are empty, right? And if we didn't have a trash man, like what would happen to our neighborhood? There was no trash man. Do you think everybody's going to take their trash and go take it out of the neighborhood, or some of that trash going to start building up all over the neighborhood?
Yeah,
it's going to start building up, right?
Yep.
Like before long, you probably have some in your house, right? You know, all your trash cans are overflowing, and you got maggots, and you know, like, I'm just being extreme here, but like think about it. Like, what if, like your kidneys are the garbage man?
Yeah.
So, and your blood is the trash can, right? So if there's no garbage man, and then the trash can just keeps getting overflowing, we got crap everywhere. And it's not just in the blood, because remember, the blood is the trash can. So if the trash can is full now, it's going to start, like if your outside trash cans are full, you might start keeping trash in your house. And that's what happens. You start keeping trash in your cells and in your brain and in your tissues. So all those areas, they have to be able to dump into the blood, and your kidneys normally take it out. With kidney failure, no more garbage man. So it's just building up everywhere. How do you get it out? Dialysis.
That's such an excellent example. Yes, excellent. I like that.
But what happens if the trash man didn't take all the trash out though? Like the trash man just took like some of it. Like you still have trash.
Yeah.
You still got some smell, you know, you still got some maggots and stuff like that, right? And when we do dialysis, we don't get it all.
Yeah.
We only get like, you know, 50% replacement, right? So like how much garbage is building up, you know? And how are the patients handling that? Like that's what we want to minimize, the appearance of all that garbage, the effects of all that garbage, right? Since the garbage man's not working 24/7 anymore, the kidneys, right? And we're only doing it 3 times a week and getting about 15% replacement. We need to, through dialysis, minimize the complications that are related to the retention of all that crap. So what crap am I talking about? Fluid, right? Chemicals like electrolytes, acid ions like hydrogen ions, waste products like urea and creatinine and other drugs and acids. So does that make sense, what I'm telling you there on the excretory side? Yeah. Kidneys stop functioning, no more excretion, it just builds up until the next time of dialysis, right?
Yeah.
So I don't know, you ever hire a day laborer or something like that to come to your house and clean up or something like that? You ever do that?
No.
Or you do it yourself?
Yeah, I'm OCD.
well let's just say, like, I mean, you got a lot of dogs, so let's use that one as an example. Like how much time do you have to put into their hygiene and their bedding and things like this every day?
Oh gosh, every day it's a few hours at least just to maintain. If I miss a day, then
it's not good.
No.
So what if you just did it every other day? You just said that's not going to be any good.
No, it will make it harder. If I don't maintain every day, I tend to make it easier on myself. But if I miss a couple of days, the every 2 days, I'm going to be doing double the work. So yes.
Yep. And then what if I said, like, you know, you said it takes a couple hours every day, but what if you just said, like, I only got 10 minutes to do it?
You can't really get anything done just with 10 minutes. I mean, you'd have to get help from somebody else. That's where I'd hire a day laborer if that was the case.
Okay.
Yeah.
So time matters, right?
Oh yes.
Time to get this stuff cleaned up, right? And blood is a mess, right? Blood is it's the garbage
Yeah.
can. Like, it needs enough time to take out all the trash. We put them on for 4 hours. We might clean up the blood, but there's
Mhm.
still trash in the house. There's still trash in the cells, still trash in the brain, things like this. So what I'm trying to get across to you guys is this excretory thing, right? When we do dialysis, we can replace those functions, but
Mhm.
we only do it for 4 hours, and we might be able to clean what's in the blood at the moment. But when the patient goes home, then it's like the house sees like, oh, the blood is clean, the trash can's, there's nothing in the trash can. Let me go dump all my crap that's built up back into the blood. So as soon as the patient leaves, like, there's this equilibration of what's in the cells and what's in the tissues, and we don't get it all, like I said. So the goal is to give the patient enough time, and enough frequency to get it out of their blood, but also to have enough time for it to move out of the cells and the tissues into the blood, so we can get that out. And there's just not like still a bunch of garbage in the other areas of the body, the other fluid compartments of the body. Okay, so that's excretory. And then endocrine. Endocrine is like when the part of the functions of the kidneys to make or convert hormones. And hormones are messengers. Messengers they're just a message. They're not an action, right? I mean, I guess a message is an action, but it's not the actual. The message is just the trigger, the stimulant. Then wherever the message went to is going to do something. Like in the case of renin and angiotensin, or renin, which is the kidney's produced hormone, to control blood pressure. How does it do it? Like, renin is a hormone that will be secreted into the blood in that nephron, and it will cause the vessels around the tubules to reabsorb sodium, take back more sodium. If you take back more sodium, then you will also, fluid will follow the sodium, because sodium is like an attractant, right? It's an osmotic agent to fluid. So water will come back, be reabsorbed as well. And if you reabsorb water into your blood, then that will contribute to blood pressure, because it contributes to blood volume. So more water, more volume, more pressure. Renin stimulates the reabsorption of sodium, which then triggers the reabsorption of water, and then which is volume, and increases your blood pressure. So right now, if I'm boring you, right, and for whatever reason your blood pressure drops, your kidneys will sense that drop in blood pressure. They will cause the reabsorption of sodium, which will cause the reabsorption of fluid, and your blood pressure will go up. That's me and you with normal functioning kidneys. Okay, and it's more complex than that. So I know you guys will read on this, but that's extracurricular, okay? Because like, renin is actually a pretty tricky. It's a part of a pretty tricky cascade. It's not just renin. There's renin, angiotensin 1, angiotensin 2, aldosterone. It's a whole cascade of hormones that are responsible for things like volume, but also dilation or constriction of the vessels. So it's quite complex. Okay, but for the sake of simplicity, on the endocrine functions of the kidneys, the responsibility is to produce that renin, which contributes to blood pressure control.
Okay.
Second hormone. The kidneys convert a hormone called vitamin D, or I should say, they convert vitamin D to its active form, which is called vitamin D3. D3. Okay, I'm sure you hear about this stuff. And then the name of that hormone, when it's converted by the kidneys, called calcitriol. Calcitriol. So that hormone is a messenger again, right? And the messenger is related to, like, your kidneys are, besides all that stuff we talked about, by the way, like, how do they know what to bring back? How do they know how to control it? They're an analyzer. Your kidneys look at your blood, right? They're like sensory. They can see how much calcium and other elements are in your blood, and what your pressure is, and what your oxygen levels are. it's a computer, you know,
Yeah.
like in refineries, you know, these big plants that they process like oil. They have these like these facilities or these components called analyzers that look at things like pressure and temperature and pH and all that kind of stuff. Your kidneys do the same thing. Okay, they analyze that blood all day long, and if they sense that your blood is low in calcium, then they're going to send a hormone out. They're going to convert this hormone, vitamin D, to calcitriol, send it out, and the hormone's going to go to your gut. And the hormone is going to tell your gut, it's a message, right, to your gut to absorb calcium from what you ate. So, like, I'm not sure if you ever knew this, but when you eat calcium, the only reason you can absorb that calcium as a nutrient is because of your kidneys. If your kidneys did not send that message, then all the calcium that you put in your mouth would be passed in your stool. You would not absorb any of it. So your diet is part of your, like, your blood values, right? What you put in your mouth is going to end up in your blood in some form or another. And that's only possible in the case of calcium because of activated vitamin D or calcitriol. Okay, it's called vitamin D3 because it actually gets converted one time before as well in the liver. So you eat like things with vitamin D in it, and then as it gets to your blood and circulates through your liver will convert it to vitamin D2, and then your kidneys will convert it to vitamin D3, which is the hormone to stimulate calcium. Okay, and then the last hormone, which perhaps is the most focused on hormone, erythropoietin or EPO. This hormone, yeah, erythropoietin can be, yeah, a little, just EPO's fine. But what does it do? It's another a messenger that will trigger your bone marrow to make red blood cells. So without your kidneys, without erythropoietin, you will not make red blood cells. You will be deadly anemic, and you would die if it wasn't replaced. So everything we talk about, like if you lost the function of fluid balance, you could die. Chemical balance, you could die. pH balance, you could die. Waste products, slowly die. Blood pressure control, die. Vitamin D, all these things are critical. Okay, erythropoietin is the same thing, critical. Anemia, can you die of anemia? Yes.
Oh yeah.
Right there, that's a, like you talked about that oxygen, right? Like that's life, man. You need that oxygen. No oxygen, everything starts to die, and things don't function. So just, you know, illustratively, like these two categories of function, they keep your blood in balance, right? They keep you in something called homeostasis. That's the orchestrated symphony, right, of what your kidneys do is that they bring that balance. They bring all those functions together, right? Like, you know, the conductor in an orchestra, like they bring the sound of all the beautiful instruments and make it one, right? And that's what the kidneys do, is they take all these functions and one word, guys, what do the kidneys do? Homeostasis. How do they do it? Through excretory and endocrine functions. What are the excretory? Water, waste, electrolytes, and pH. What are the endocrine? Erythropoietin, calcitriol, renin. Lock it in.
Okay.
Lock that in. Okay. You got to know this once. You got to know it intimately, because you're going to see your patients when they come in. They're swollen. Their blood pressure's high. And by the time they leave, that should all be corrected. But maybe when they leave, they're still swollen. Their blood pressure is high. Do you think you got all the fluid? No. Okay. A patient who is getting adequate dialysis should be relatively normalized as far as blood pressure and swelling and electrolyte levels and waste levels. They should have good appetites, and they should be sleeping well. And If they're not getting good dialysis, you'll see all sort of complications manifest. So like I said, there's a massive amount of blood that is filtered through your kidneys per day. 4 to 5 gallons on average, they say about 425 gallons per day. And it's running through your kidneys, and the 2 to 2.4 million nephrons that are combined between both kidneys, and it's constantly producing filtrate. So what happens first? Filtration, right? In the nephron, right? Filtration. Everything is filtered out. The average GFR, glomerular filtration rate, not the one that is in this picture, not per day, but glomerular filtration rate per minute is 125 milliliters. Per day, about 180 liters, which we don't have 180 liters of fluid in our body, right? So it makes 180 liters of filtrate because it's constantly doing that filtrate. But remember, almost everything is reabsorbed. And then per day, how much ends up in that toilet? About 1 to 2 liters of that 180 liters. The rest of it, your body takes it back because it's needed. So take it all apart, right? The blood, and rebuild it. Every single beat of the heart. That's what happens. Are you guys having a new appreciation for the kidneys?
Oh, very much so. I've changed my whole diet. I have a sugar problem, so now yeah.
Yeah, you got to keep that one under control. We know
yeah.
that, and that's not anything that you're not special there, Kenlyn. There's over 100 million Americans that have sugar problems, right?
I'm in the worst state ever. I used to be a Pepsi addict.
Oh yeah, yep.
And then I discovered sweet tea from the South.
Yeah. Oh yeah. Well, hey, I mean, I like Coke too, and there's like a lot of there's a lot of responsibility being put on these companies today for their contributions to the diabetes without any really sense of education or kind of moderation type of conversations. There are people, and myself included, there's been days where I didn't drink anything but Coke, like the whole day I was like, I'm thirsty, get a Coke.
It's hard.
So you're right. I think the lifestyle stuff for especially in America is very difficult. We have all the convenience in the world and all the luxury to be able to kill ourselves with a smile on our face.
Yeah, it's gonna change after I'm done with this course.
So let's just drill down each of these. The balance of electrolytes, right? Electrolytes are minerals that conduct electricity, and depending on which electrolyte, they're all supposed to be in certain ranges. You got a potassium level, a calcium level, phosphorus. They're all levels that we have thresholds for, right? That you're supposed to be in normal ranges. If you're too high or too low, there's going to be some problems. That's why there's those reference ranges when you get the labs, right? If your cholesterol is too high or whatever, like you're at risk for this, and this, right? If your cholesterol is too low, you're at risk for this and this and this. And same thing with all these electrolytes. So, like a couple notable electrolytes, and we'll talk more about these, but like potassium, for example, if it's too high or too low, your muscles are going to not be able to function properly, and your heart's a muscle. So potassium could be like life-threatening. Literally, if you eat too much avocado or strawberry or mango or something like that in a day, like you could kill yourself, like just like that. And I want you to kind of in the back of your head throw that out there, that like we do have a lot of patients who have suicidal ideations, right? Like they are depressed and they may express that they want to kill themselves or they want to die or things like this. And there's all these crazy ways that people do that kind of stuff, right? That they try to hurt themselves, and sometimes it's direct to the point, and other times it's more call for help, right? But if you think about like a dialysis patient who truly was in that mentality, it is so easy, and I could do it with a smile on my face. What's my favorite fruit? What's my favorite drink? You know, let me drink a 40 ouncer or a couple 40 ounces of beer, just get myself, you know, shitty drunk. And I'll be happy, but I'm going to be so fluid overloaded that I might die.
Yeah.
Let me go and eat, like I said, you know, a basket of mangoes with what do you call it, Joanne? Is it called what's the little shrimp sauce? Baga. My wife eats it all the time. Bagaong or something like that. Yeah, yeah. So like she'll sit there and eat like, you know, 3 or 4 mangoes, and of course high in potassium for her, that's fine. But if I was a dialysis patient, I love mangoes. I might be able to eat a couple small cubes. If I eat a whole mango, I'm in trouble.
Yeah.
So again, you know, that's one that's kind of critical. But you know, what about like a phosphorus or something like that? If I have too much phosphorus or too little phosphorus, it's going to really the main area it's going to impact is like my bone remodeling, my bone structure, my bone health. Calcium, you know, bone health as well, but also critical to muscle. So when these things are too high or too low, depending on which electrolyte, they all have their specific function. So the complication would come in that specific function.
Yeah.
And then with the pH, you know, we have this substance in our blood called hydrogen ions, and we measure pH on a scale of 0 to 14, where 7 is the neutral number. It's like not acid or alkaline. So what do you mean pH? Acid or alkaline? Okay, low pH or high pH. 7 is neutral. Below 7 is acid. Above 7 is alkaline. Your kidneys normally keep you slightly alkaline, 7.35 to 7.45. That's the function of the kidneys, to keep you in that regulated pH level, and it's always very tight. That's a very tight range, 7.35 to 7.45, very tight. Okay?
Yeah.
Your kidneys are that good. Your kidneys and your lungs. Okay, but to do that, like what your kidneys do is they take out the acids through excretion, and then they also have a substance that can be secreted in the blood called bicarbonate. Bicarbonate is like a buffer. It's like baking soda.
Yeah.
Same thing. Okay.
Okay.
But it's a buffer, and it will neutralize acid, but it will also neutralize alkaline. So it keeps the patient's blood relatively neutral. Okay. 7.35 to 7.45. When a patient has kidney failure, they're not going to get rid of the hydrogen ions, and they're not going to secrete bicarbonate. So they're going to have something called metabolic acidosis. When your kidneys fail, you have a problem with your pH. Your kidneys are supposed to keep it in check. They stop functioning, you're going to have problems, right? And that metabolic acidosis is actually life-threatening in itself as well. But they come to dialysis every couple of days, and we get rid of the hydrogen ions, and we run them on dialysate that has bicarbonate in it. So we correct that metabolic acidosis every single time they come into dialysis. The time where they get the worst is that weekend, remember? The weekend is the time where you have the most time off, and things tend to get the most out of control.
Yeah.
And to tell you the truth, we call it the killer gap, where on Mondays and Tuesdays, like the first day that the patient is back or like back on dialysis, or even like their longest time without dialysis, patients die on Mondays and Tuesdays, guys.
Really?
Yes.
Wow.
Like
Wow.
double the amount that die on Wednesdays and Fridays, or sorry, any
Wow.
other day of the week. So if you're Monday, Wednesday, Friday, your highest risk for death is Monday. If you're Tuesday, Thursday, Saturday, your highest risk for death is Tuesday.
Wow,
And
that's
it's like double. They also, the kidneys remove waste. And this one, by the way, your kidneys don't reabsorb this stuff. This one just like straight out, right? Straight shot. Metabolized foods. So metabolized foods, the waste that are produced through metabolized foods would be something called urea. Or you may hear it called BUN, blood urea nitrogen, but the substance is called urea. Okay, so When you metabolize foods, the urea is produced mainly through protein, specifically high biological value protein, like what you take in from milk and cheese and eggs and meat.
You know, this
So,
really helps a lot because I do lab work and I always was so
mhm,
confused about, you know, I do chemistry panels all the time and, you know, you do the
yep,
electrolyte, you know, and now it's like really kicking in. So that's great.
clicking.
Yeah.
So that's one waste, urea, BUN, from metabolized foods. But then there's also this other waste that we really watch, and it's usually the primary marker for kidney failure, called creatinine.
Mm,
Creatinine.
okay.
Okay, and that creatinine is another waste product, not from metabolized food, but from the breakdown of your muscle or your tissue. And we all break down tissue every single day, every single night. By the way, guess when you lose the most weight?
When you're sleeping?
Yep, you break down and rebuild like a whole lot, man. It's incredible. Like if I mean, we're talking like 2 to 3 kilograms of
Yeah.
loss and rebuild. You usually wake up a little bit lighter, but your body is actually taking it apart and rebuilding it. Okay, um, so with this breakdown of tissue and muscle, like why would that happen? Well, if you exercise, that happens.
Mhm.
And then also, if you don't exercise, that happens. Weird, right?
Yeah.
Like you exercise a lot, you break down and build new muscle, right? You're synthesizing protein as well. But if you don't exercise, or you don't have activity, what happens to people's muscles? They just shrivel away, right? They
Mhm.
atrophy, and there is a breakdown. So that creatinine is produced at that time. Okay. If you're malnourished, like if you don't have enough protein, then or even enough calories, then you might sorry, I just saw my niece. She's my buddy. She's like 2 or
Mhm.
1 or 2. My wife's watching. Sorry, anyways. So
That's
so with that breakdown, or with the loss of protein, your body will, or sorry, with a deficiency in protein or calories, your body will consume itself. Right? We know we have to go into calorie deficit when we're trying to like lose pounds, right? We go into calorie deficit. But I don't know if you guys have ever paid attention to this. Like you go to calorie deficit, but you need protein.
Hmm.
Right? Like you go into calorie deficit, but you don't want to like have a protein deficit, because if you're trying to lose pounds, what kind of pounds are you trying to lose? The stuff that's hanging off your muscles, or are you trying to lose your muscles?
No, the stuff that's hanging off the muscles, right?
Exactly. So if
Mm.
you cut your protein, then you will guess what you will consume first. Like if you don't have enough calories or protein, the place that you're gonna go for a source of nutrient is your muscle. You're not gonna
Mhm.
eat your fat first. So protein is a huge requirement, for like maintaining size and muscle, and as far as calories, like the calorie deficit to lose weight, you don't want to do that through cutting out protein, right? So when you look at these wastes, like the metabolized food, the urea that's being produced from protein, the broken down tissue is being, or the creatinine is being produced from broken down tissues. Why do tissues break down? Exercise, sleep, malnutrition. If
Yeah.
you're malnourished, you use your body as a source, right?
Mhm.
And then just all the toxins, like drug, over the counters. And I saw some doctor say the other day, what did he say? Extracurriculars, extracurricular drugs, all that stuff. Your kidneys takes care of it. Um, so the removal, the excretion of waste. So those
Mhm.
are our excretory functions, right? And then we have the endocrine function of the erythropoietin, which I'll start with that because it really is our primary focus. The patient will have anemia, all of them, secondary to ESRD. It's caused because they have kidney failure, right? When they
Yeah.
have kidney failure, they lose erythropoietin, so no chance of making red blood cells. But how does this whole cycle work? You got red blood cells, you got your kidney, you got the hormone, you got the bone marrow that makes red blood cells. So let's start with blood. Okay. let's say your blood is low in red blood cells. So it's going to be low in what? Low in oxygen, because your red blood cells carry oxygen, right?
Yeah.
And your kidney is, what did I call it? What did I say, that word about all the sensory and stuff? Analyzer.
Oh, analyzer.
It's an analyzer. So it looks at the blood and goes, hey, not enough oxygen. Let's spit out the hormone erythropoietin and tell the bone marrow to make more red blood cells. When there's enough red blood cells, your kidney knows it. So there's no secretion of EPO, right? But when you're lacking oxygen, or when the threshold is hit, your kidneys sense it and spit out the hormone. So that's, you don't have to ask your kidneys to do that. You're gonna have to inject the medication. They just know. And you should not end up anemic because of a lack of erythropoietin. Okay, let's talk about anemia for a second, just high level again. Anemia in the general population is mainly attributed to iron deficiency. Where does iron deficiency tend to happen? In females, right? With the menstrual cycle and the loss of iron. So it is not an uncommon phenomenon in the general population to have anemia. There are other forms of anemia as well that are not related to iron deficiency, but more to the cell itself, sickle cell and black diamond and things like this, right? But let's kind of focus on general anemia and then ESRD anemia. General anemia, iron deficiency is part of it. It's not the erythropoietin, it's the iron deficiency. And iron is needed to help red blood cells mature. Okay? So if you make a baby, you got to feed a baby or else it won't grow. Right? If EPO stimulates the bone marrow to make red blood cells, they're babies. They're not carrying oxygen yet. They need iron to grow. So in general population, if there's iron deficiency, your red blood cells just won't mature. If you have ESRD, when your kidneys fail, you stop producing EPO. Your bone marrow will not make red blood cells unless it's stimulated. So that's the secondary aspect of it. Is iron still important? Yes. Could iron deficiency still contribute to the anemia? Yes. Are females more complicated than males in treating anemia? Yes. Okay. But we have to treat this, man. Like, all of our patients are going to die if we didn't have like erythropoietin or EPO replacement. We call it EPOGEN. Or there's a couple of, EPOGEN has like been the historic medication that's been used for the longest time. There's another medication called Procrit. It's the same thing, but it's not used in ESRD. It's mainly used in like cancer. And then there's a few other medications that are newer to the market. One that's made from the same company as EPOGEN. It's called, the company's called Amgen. And they make another medication called darbepoetin alpha, or Aranesp. So EPOGEN and Aranesp. EPOGEN given every treatment, Aranesp given once a week. And then there's another newer medication that I haven't worked with called Mircera. So there are different types of replacement for EPO that the nurses will give to the patient when they come to treatment. We have a nurse that works with us. Her name's Ann Dearle. She is one of the nation's top, like the nation's top educators as far as nephrology nurses for things like anemia, fluid management, as well as oxygen management. And I suggest you kind of look her up. Go to YouTube and look up our school name as well, and you'll see a presentation that she gave not long ago on oxygen. It's a little lengthy, but it's in video, so you can pull it up. Let me see if I can drop the link in chat, okay? So that way you guys don't gotta go find it. Hold on just a second.
March 22nd.
Okay, so I'm gonna put a link in the chat. It's for our YouTube channel. And actually, I think you guys will really like checking it out because we have a few videos on there. One that's broken down into 3 individual hours. It's about home dialysis. And then one that's like an actual 3-hour segment about oxygen saturation and hemodialysis from Andy Roll. So yeah, check out, you guys see the link?
Yes.
Yeah, save that link and just subscribe to the channel, and that way you can visit, because we'll be dropping videos in there like pretty much monthly, okay? On different topics as we do continuing education events. All right. So any questions about this cycle here?
No. Nope.
Get it, Joanne?
Nope.
Yeah. So then we look at the calcitriol, right? The conversion of the vitamin D that you put in your mouth, right? By the way, the sunlight is not inert. It's actually converted vitamin D. Sunlight is a natural source of vitamin D3. Okay, you should get a little bit of sunlight every day, right? Not too much, not too much direct sunlight. But like the eggs and cheeses or dairies and those fish and stuff like that, high in vitamin D, but they're in an inert form. They need to be converted. Like they're not in a form that's gonna have any action. In other words, they need to be converted before they will actually do anything, or vitamin D will do anything. So first thing that happens is, you ingest, it ends up in your blood, it circulates through your liver, and your liver will convert it one time. Then it will continue circulating, and it will move through your kidney, and it will get that second conversion, which turns it into vitamin D3. Vitamin D3, calcitriol. Okay. So if your kidneys shut down, you don't convert it. And if you don't convert it, it doesn't do what it's supposed to do. So in other words, if you lost vitamin D3, like what's going to happen? You're not going to take any calcium from your gut. So your blood is used to being fed from your gut, right? Like it's used to being fed calcium from your gut, like through that absorption process. If you don't get calcium through your gut, where are you going to get it? Because your body's that what do I call it, the conductor, right, of the symphony. And man, if the tuba don't work, then I'm gonna call on another instrument to make that noise. Or if I don't have a tuba, I'll find another instrument that can make the same tone, or so what's the body going to do? What's the other instrument of providing calcium? You eat calcium, but if you're not getting it from what you eat, where could you get it in your body?
Good question. I don't know.
Your bones and your teeth.
Oh,
that's the piggy bank, right?
Bones and teeth. I'm confused about that calcidiol and the calcitriol. Is that just because it's going to different parts of the body and it's a different name?
No, it's circulating, and as it passes through the liver, that vitamin D is converted to calcidiol. And then as it passes into the kidney and it goes through the kidney and is converted, it converts to calcitriol. That's why it's called vitamin D3. First one is that inert form. Then it gets converted to vitamin D2, then D3.
Okay, that makes
so
sense.
calcitriol is D3. Yeah.
Okay.
And then if you don't have calcitriol, you will not stimulate the gut to absorb calcium, so your blood calcium is going to fall. And if your blood is low in calcium, your kidneys are going to sense it, or your body's going to sense it as a whole, and there is going to be some attempts to go find calcium somewhere else, since you can't get it from your gut. The only other source of calcium in your body that without ingestion or supplementation is to just steal it from your bones. Because like 99% of your calcium in your body is in your bones, right? So
Is that
So
why
take
bones get fragile, like the older you get because of this?
um, the the older you get, no.
Okay.
Related to a kidney patient, yes. The stealing of calcium from the bones or the demineralization of bone as a nutrient can
Mhm.
cause to weak, fragile, prone to fracture, poor scaffolding type of bones. Yes,
Yeah. Okay.
it's called osteodystrophy.
Mm,
What you're talking about, like the aging process, is more porosis, osteoporosis.
okay.
Okay, so similar process, just not the same cause, not the mineralization cause.
Okay. Just a few. All right.
So those two hormones are big deals, and you're going to notice I don't have a slide on renin, or maybe I do actually. Let me see. No, I don't have a slide on renin because renin is not a hormone that needs to be replaced now. With renin, and I'll give you the explanation of renin. So with renin, it's a hormone that is secreted in the nephron related to blood pressure. So if you have a low blood pressure that your kidney as an analyzer can sense, and there's like a whole story on that sensory. Like there's certain parts of the kidney, right? Certain nephrons, they're called juxtaglomerular nephrons that have that sensory ability. Um, with the sense of that low pressure, will secrete the hormone renin, which stimulates the peritubular capillaries to reabsorb sodium. So take back sodium that was filtered out. And then when sodium is taken back, then it will cause like a higher flow of water to be reabsorbed as well. Because remember, in the nephron, we filter everything out, including the water, right? And we got to
Mhm.
take it back. Renin will just say like, take back more sodium that will then bring back more water and increase the volume in your vessels and make your blood pressure go up. So like if you have low blood pressure naturally, your kidneys will correct it naturally.
Mm, okay.
Okay. Any questions?
Hmm. Now a lot to take in.
Yeah, this is a small bite actually, guys. But you guys are a thoughtful class, so um, I gotta say that, and I think I said it. We're conversing more than most classes, which is good. So we're a little bit behind normal timeline, but it's not going to be a problem at all because we do have some weeks that kind of lighten up, and just try to stay up on your reading, and then in discussion try to stay current with the discussion time. Okay, like even if we're still talking about last week's topic, stay up on the discussions with what the topic of that week is. Okay, and stay up with the reading as well. Stay on pace with that, even though we are a little bit behind on like getting through module 2.
Okay.
Okay,
Sounds
and
good.
then text me, call me if anything. We do have a review tomorrow. If you guys want to participate, it's a little lengthy, but it's specifically for certification review, and you guys are early in the course. I do it every month, so you don't have to come. But if you want to get an early start on like just prepping for test, you're welcome to come. Did you guys both get the invite for that?
Oh, yes, I did. Yes. It's gonna be, I think, 1 o'clock my time. So it's 11 o'clock in California. Yeah, I did get that. Yeah, I will
Wait,
be there.
wait. Hold on. Let me make sure because that doesn't sound right.
There was one that was canceled. No, there's another one also for the. I got a couple of those.
Yeah, there was a review, and then there's a CE event.
Yeah,
The
I think
review, the review is the one that is this Sunday,
8 p.m.
Sunday, and it's 8 a.m. So your time it's 11 a.m.
Yeah.
You're 3 hours ahead, Kenlin, or
No,
2 hours
I'm
ahead?
only 2 hours.
Yeah, so it's 10 a.m. your time.
10 a.m. Yes,
I'll show
I'll
you
be
my
on.
calendar. So let
Okay.
me show you my calendar really quick, just so you.
Yeah. So yeah, I will be there for that.
So that one, 8 to noon. And you guys are both on here, right? Let me see.
Yes.
Where's your name?
Kenlyn.
Oh, there
at
you
Gmail.
are. And then Joanne right there. Okay, cool. Yeah. Again, you don't have to come. I do not record that one at this time. It's just something I do every month, and you guys will also have it built into your course in week 9. But I do it every month, just that way that you can get it repeatedly, and just overdo the preparation, right?
Yes. Yes. Perfect.
And I'll say this: if you take advantage of that stuff, like, success should be no problem. We don't have like a 100% of our people pass the test the first time, and I'll just tell you, the people who don't pass it the first time don't do their work. Like they don't put the effort in. This is not hard stuff. I think we lay out a pretty simple roadmap for you and give you all the tools you need, but you got to put in the time outside of our meeting times as well, which I can tell you guys are doing. So keep it up, okay?
Sounds good.
Have a great day, both of you.
All right.
Weekend.
See you on Tuesday.
Bye-bye.
Bye.
Mommy, I did